Okay. Good morning, all. Today's lecture we have chronic myeloid leukemia and other myeloproliferative neoplasms. So this is a big topic. So in this, we roughly divided into two parts. One, in the first half, we study chronic myeloid leukemia, and in the later half, we study the other Mpns. So what are myeloproliferative neoplasms? What does the term imply? So it's self-explanatory. The term myelo meaning marrow and proliferative meaning proliferation. So there is a lot of cells proliferating in the marrow. So as you can expect, there is a hypercellular marrow with proliferation of different types of cell lineages. So when there is a lot of cell proliferation in marrow, it reflects in increased cell numbers in the peripheral blood. So you have a combination of myeloproliferation and increase in blood cell numbers. This could be increase in RBCs resulting in polycythemia, increase in WBCs resulting in leukocytosis of different cell lineages, as well as thrombocytosis. So it's a generalized myeloproliferation. It is not related to any particular lineage. This arises from the multipotent hematopoietic stem cell. So normally, what does a multipotent hematopoietic stem cell do? It can proliferate into multiple cell lineages. It can proliferate into a erythroid cell. It can proliferate into a granulocytic cell. It can proliferate into a megakaryocyte. So in an abnormal condition or a neoplasm arising from the multipotent hematopoietic stem cell, there is increased proliferation of all these type of cells. One important thing we have to note, in last class we studied about acute leukemias. In acute leukemias, there is increased proliferation, but the maturation is absent, meaning the cells are stuck at one point of maturation. That is, they are in the very early stage. Only blasts are seen, or mainly blasts are seen. Here, the maturation is intact, meaning the cells mature into, the blasts mature into different types of mature cells in the peripheral blood. They mature into neutrophils, they mature into eosinophils, they mature into monocytes, platelets, RBCs, etc. So because of increased proliferation, resulting in all the cells maturing, there is increase in the blood count. There is elevated blood count. As you know, when there is increased cell proliferation, these cells get engorged within the organ systems. The main reticuloendothelial cells organs are liver and spleen. So this results in hepatomegaly and splenomegaly. So there are minor subtypes, but mainly there are 4 subtypes of Mpns, or myeloproliferative neoplasms. The most common and most important one is chronic myeloid leukemia, or CML. The other 3 types are polycythemia vera, essential thrombocythemia, and primary myelofibrosis. The names are self-explanatory to some extent, so we will study separately to understand them, understand the features of each of these Mpns. So what differentiates CML from the other 3 Mpns? CML is a disease which is pH positive, meaning it's Philadelphia. What does pH mean? pH means Philadelphia chromosome. So what is Philadelphia chromosome? So it is a particular type of translocation which is seen in this abnormality. It's a translocation 922 seen in chronic myeloid leukemia. The other myeloproliferative neoplasms, they don't have this characteristic Philadelphia chromosome. So we call them PS negative Mpns. We will start in the first half. We study CML. We'll start with a small introduction. Then we see a little bit of pathogenesis and move on to the other features, diagnosis, and treatment. CML is a prototype myeloproliferative neoplasm. It originates in an abnormal bone marrow stem cell, and the characteristic feature is the presence of the Philadelphia chromosome or BCR-ABL1 fusion gene. So, when the Philadelphia chromosome is the result of a translocation 922, the translocation basically results in the fusion of two genes, BCR and ABL1 gene. And this BCR-ABL1 fusion gene is responsible for the different effects of CML. So, CML has a special history in the hematology. It is called as the disease of first. There are many things which are first in hematology, which happened with CML. So, what are these? So, CML is the disease in which the term leukemia was used. So, as you studied in the last lecture, leukemias can be acute or chronic leukemias. So, CML comes under the category of chronic leukemias. Before leukemias was used for other blood cell proliferation, it was first in CML it was used. In the early days, the cause of the blood cancers and leukemias was unknown. So, CML was the disease in which the first the chromosomal abnormality underlying the disease was known. So, what was the chromosomal abnormality? So, we studied just a bit ago that Philadelphia chromosome or translocation 922 is the abnormality underlying CML. So, the translocation as an association with the disease or causation of a disease was first known in CML. Now, we know that chromosomal abnormalities underlie many other hematological neoplasms, even other solid tumors. So, a lot of chromosomal abnormalities are associated with different cancers, but CML was the first disease in which it was described. So, it was the first disease in which reciprocal translocation, translocation 922 was recognized. And also, it was the first disease in which the specific gene fusion. The gene fusion basically resulted because of the translocation, and this was first diagnosed in CML. So, what was the gene fusion? The gene fusion was fusion between two genes, BCR gene and ABL1 gene. Nowadays, there are a lot of gene fusions described in different types of blood cancers, different types of solid tumors, even in lung cancers, even in GA cancers. But the first gene fusion of BCR and ABL1 as a result of translocation in a particular disease was first described in CML. It's not just the pathogenesis, the genetic makeup, the chromosomal abnormality or gene fusion, which was first described in CML. Even first targeted therapy was first discovered in CML. So, you might have heard of the drug called imatinib. So, imatinib is a tyrosine kinase inhibitor, which is still widely used in chronic myeloid leukemia. So, it targets the BCR-ABL1 fusion transcript. So, the first description of a targeted therapy was first happened in CML. So, before that, people used chemotherapy, cytoreductive therapy. So, it was a general type of disease control or treatment. Specific targeted therapies have become largely available these days for different types of tumors and even some benign conditions. But the first it happened in CML. So CML gets a special place in hematology. Though the disease was first described in 1840, the description of the disease was given. It was only in the 60s that Novel and Hungerford described this particular type of chromosome, which is the Philadelphia chromosome. So this is because of a translocation between 9 and 22. So here we have a normal chromosome 9, normal chromosome 22. This is the abnormal chromosome 9 and abnormal chromosome 22. So why is this abnormal? So here some part from here has come here and fused here, and this because of this chromosome 22 has become smaller. So this small chromosome 22 is called a Philadelphia chromosome. And this two scientists, Nowell and Hungerford, observed that the small chromosome 22 is frequently observed in CML patients. So this was described in the University of Pennsylvania, Philadelphia. So it was named as PH or Philadelphia chromosome. This Philadelphia chromosome, the cause was not known. They just observed that there's a small chromosome. So it was in 1974, Janet Rowley, she understood why this happened. So she described that this is occurred because of translocation between chromosome 9 and 22. In 1984, the result of the translocation, that is the BCR-ABL1 fusion, was discovered, and work started on how to target this particular fusion transcript and its protein. So it was in the 90s that the drug imatinib was discovered, and it was put for trials. And the trials completed in the early 2000, which showed that this imatinib shows complete remission, and it acts by working on the BCR-ABL mutation. So there are a lot of other newer drugs which have come up based on imatinib, which are dasatinib, nilotinib, which are higher inhibitors compared to imatinib. So what underlies this CML? So we knew that it is a translocation between chromosome 9 and 22. So chromosome 9 is a large chromosome, whereas chromosome 22 is a smaller chromosome. So what happens? There is this part of this chromosome 22 which breaks at this BCR breakpoint, and there is this small part of chromosome 9 which happens at this where the ABL gene starts. So this is the ABL gene area. So in a translocation, one part of the chromosome goes to the other part, and the other part from the other chromosome switches to the first chromosome. So here, this part starting from BCR from chromosome 22 goes and translocates to chromosome 9, whereas this small part of ABL, starting with ABL from chromosome 9, goes and translocates to chromosome 22. So normally the part of ABL is smaller compared to the BCR part. So the resulting Philadelphia chromosome gets only small amount of genetic material from chromosome 9. So it appears smaller in size. So this was what was observed as a smaller chromosome 22, and they called it Philadelphia chromosome. So here they say that the break occurs at Q34. So this is basically Q is the long arm of chromosome. So it occurs at the long arm of the chromosome, position 3, 4. So how does this BCR-ABL fusion occur, affect or cause CML? So it happens at a stem cell stage. So normally what happens is stem cell divides into myelin progenitor, lymphoid progenitor, and then it divides into different types of mature cells like monocytes, neutrophils, RBCs, platelets, T and B lymphocytes. So when there is a BCR-ABL fusion, there is increased proliferation of this. So increased proliferation of the stem cells as well as differentiation of the stem cells. So when the stem cells differentiates, they form more number of all these differentiated cells. So we have more number of neutrophils, more number of monocytes, platelets, etc., etc. So that results in leukocytosis. So normally this happens in chronic phase. So we will study in a while that the CML has other phases also, blast phase and accelerated phase. Here additional mutations occur. It's a very busy slide. This is to understand how the BCR-ABL affects the different signaling pathways. So here we have a fusion transcript which results in a fusion protein, BCR and ABL. So it downstream, normally it has effects on different types of cellular activities and different types of pathways. So what happens in CML, this is constitutively activated, meaning there is no stop mechanism. Normally when these proteins are activated, there is a stop mechanism. Because of this fusion, they overcome the stop mechanism, resulting in continuous proliferation. So the pathways involved are STAT, JAK, mTOR, AKT, etc. So normally these pathways result in increased proliferation, whereas in CML they are multifold affected. BCR-ABL fusion happens, there is increased tyrosine kinase activity and constitutive activation of several signal transduction pathways, which results in a leukemic phenotype. This affects the proliferation, resulting in deregulated and uncontrolled proliferation. There is defective apoptosis. So normally when there is proliferation, it is equally accompanied by an apoptosis, so that there is a check on the proliferation cells. Here, unfortunately, there is no, the check is removed, so there is defective apoptosis, resulting in increased survival. This results in increased myeloproliferation, resistance to apoptosis, resulting in increased survival, and absent or perturbed interaction between the bone marrow stromal cells. Normally, the bone marrow stromal cells have a negative influence on the proliferation, but when that defective feedback is lost, there is uncontrolled proliferation, and also there is genetic instability. So this BCR, so every fusion protein and every fusion transcript has a specific molecular weight. So here there are 3 different types of fusion transcripts, so that there are 3 different products. This 210 refers to a 210 kilodalton product, 110 refers to a 1 kilodalton protein, and 230 refers to a 230 kilodalton. So this is because of minor breakpoint differences where the Philadelphia chromosome breakpoint occurs. So accordingly, this is called major, minor, and micro. And there are small phenotypic differences which are seen because of this breakpoint. But all occur in CML, the common one being the B220, which occurs in 80 to 90% of the cases. So how does this behave naturally? So it is it has 3 phases, commonly a chronic phase, accelerated phase, and blast phase. As the name implies, the chronic phase is relatively indolent. It goes on for a few months to years, whereas accelerated and blast phase, they are very aggressive phase of the disease. If untreated, the patient succumbs to the disease in weeks or even months. So normally, if it's a chronic phase, if it's untreated, it has a few years survival. The patient has some symptoms. These days, the symptoms are treated. If not treated, it goes on to blast crisis and or accelerated phase. When the patient goes on to accelerated for a blast phase, it results in death maximum within a few years. So how does this patient present? A large proportion of these patients are asymptomatic, and they are diagnosed on routine clinical examination. This is true especially with chronic phase diseases, chronic phase patients, because they just have some non-specific symptoms. This include fatigue, weight loss, upper quadrant fullness. So upper quadrant fullness is because of the splenomegaly. Splenomegaly is consistent. It is seen in 50% of the cases, and it can be palpated. Even in the other 50%, the spleen may not be palpable, but still there is splenomegaly, which can be seen in a radiological examination. Other rare manifestations include bleeding. This is due to platelet dysfunction. Thrombosis can occur because there is a lot of blood cells in the peripheral blood. So when there is a lot of blood cells, these blood cells clog the blood vessels. They stick to each other, they stick to the blood vessel wall. So this results in the thrombosis. So whenever there is any increased cell proliferation, the increased cell breakage also happens. So when the cells break, there is a lot of uric acid produced, and this gets deposited in the joints, resulting in gouty arthritis. Because of leukostasis, there is too much white blood cells in the peripheral blood. This results in different leukostatic symptoms. Hemorrhages can occur because this leukostasis can damage the smaller blood vessels. But when the CML transforms meaning when it becomes into accelerated phase or blast phase, it results in symptoms suggestive symptoms consistent with acute leukemias. It's a disease of middle and old age. It usually happens after 50 to 60 years. Indian patients are younger. The reasons is unknown. It happens 40 to 50 is the median age group in Indian population. It has a slight male preponderance. Though CML can occur in childhood and adolescence, it is rare. It is common in older age. So we have seen the symptoms and examination findings. Sphenomegaly is a consistent and important finding to look for in CML. What are the lab tests we do to diagnose this? So we diagnose using a complete blood count. Complete blood count will show increased blood number of cells, and there is presence of neutrophilia, basophilia. The peripheral smear examination will tell you the type of cells present. Leukocyte alkaline phosphatase or a NAP score is done to look at the neutrophils. In CML, the lab or NAP score is reduced. It's low. Bone marrow aspiration biopsy will come to the findings, karyotyping to understand the basic recurrent cytogenetic abnormality. Rarely we use flow cytometry. This is used only in blast phase, not in chronic phase. And test to diagnose this BCR-ABL1 translocation. Complete blood count and PS show leukocytosis, neutrophils in various stages of maturation, meaning we see mature neutrophils. Like here, we have immature neutrophils, so we have a metamyelocyte here, we have a myelocyte here. So we can see not just neutrophils, you can see the precursor of neutrophils also. And you can see the numbers are very high. You can see this slide with a lot of granulocyte cells. You can get hypersegmented polymorphs. There is a myelocyte bulge, and there is thrombocytosis. So you can see the platelets here. So they are in clumps here. So here again we have platelets in clumps. So normally we see platelets scattered in between the RBCs. Because of increased platelet numbers, they tend to be very close or sticky to each other. The anemia is usually mild and it's normocytic normochromic, and basophilia is a consistent feature. Yeah, sorry. So what are the other differential diagnoses? So CML can be confused with other conditions because they have some things in common. It's frequently confused with leukemia reaction. So what is leukemia reaction? Leukemia reaction is a non-malignant benign proliferation of blood cells as a reaction to a stimulus. We have to understand that leukemia reaction can occur in infections, it can occur in some immune conditions, but once the stimulus is removed, once the infection or the inflammation is gone, the blood cell numbers go back to normal, whereas in CML, the blood cell numbers don't go back to normal. So how do we differentiate these two conditions? In leukemia reactions, the total count is usually less than 50,000, whereas in CML, it's usually higher. It's in the range of 50,000 to 1 lakh or even more. And in leukemia reaction, you can see toxic granulations, whereas in CML, the granulation is not affected. Basophilia is commonly seen in CML where it is absent. And we learned something about leukocyte alkaline phosphatase levels. We'll come to that in a bit. So this leukocyte alkaline phosphatase, which is an enzyme which we detect using some tests. This level is increased in leukemia reaction. So using all these criteria, you can differentiate CML from leukemia reaction. When the steroid therapy is given, it can induce leukocytosis. Patients on GCSF therapy also have increased TLC or leukocyte count in the peripheral blood. There are other myeloproliferative neoplasms which can also have increased total leukocyte count or white blood cell count. So those also can be confused with CML. This includes the polycythemia vera, essential thrombocytosis, etc. So what is this lab score or NAP score, neutrophil alkaline phosphatase score? So neutrophil alkaline phosphatase is an enzyme which is present within the neutrophils here. So these are the neutrophils. So all these cells are neutrophils here. This is a neutrophil. This is a neutrophil. This is a neutrophil. So they look different from what we normally see because this is not a normal chromonoskis type. This is a leukocyte alkaline phosphatase type. So in this, what we do, we stain the granules present within the neutrophils, and they appear blue in color. So you can see the cytoplasm here, which appears blue. So a normal individual has presence of these granules, and in conditions like leukemia reaction, this granulation is increased. So you can see this blue color in all these cells. So we do a grading of 0 to 4. 4 is maximal staining. Normally it is in the range of 30 to 130. It is increased in leukemia reactions and other Mpns. Whereas in CML, what happens? This staining is lost. So we get very low scores. We get scores less than 35, and it can sometimes even range from 0 to 4, etc. Okay. So this will help us differentiate between, if there is leukocytosis, we can differentiate between CML and other types of leukocytosis. We do bone marrow biopsy to see certain morphological features. So we'll go to the picture itself. So what happens in the bone marrow? So in bone marrow, you can see a lot of cells. So you can see it's a very hypercellular marrow here. Normally we have fat spaces and bone marrow here. It is just bone marrow cells everywhere. And we can see this increase in megakaryocytes. So there is a megakaryocyte cluster here. There is a megakaryocyte cluster here. So 1, 2, 3 megakaryocytes. So normally the megakaryocytes are scattered. So here the megakaryocytes are increased in number, so they occur in clusters. And also the megakaryocyte morphology is different. Normally megakaryocyte is a structure which, so this is a megakaryocyte. You can see a multi-lobed megakaryocyte. So you have this megakaryocytes with multiple lobes. Whereas here you have only a dwarf megakaryocyte with 1 or 2 lobes. So it is very small in size, and then so we call it a dwarf megakaryocyte, and the lobation is also reduced. And you can see in the background you have a lot of this granulocytic cells. So you have neutrophils here, and you have myelocytes here, metamyelocytes. So there's all types of cells present in the background. And because of increased number of cells, there is increased cell turnover also. So you get something called a pseudo-Gaussian cell. So this is a cell which appears like a Gaussian cell with crumpled tissue paper appearance. But this is not a Gaussian, this is just a histiocyte. So we call it pseudo-Gaussian cells. So these are all features of bone marrow seen in a case of chronic myeloid leukemia. The Differential biopsy shows a hypercellular marrow. There is no fat spaces. Again, here you can see a lot of megakaryocytes. So there is a megakaryocyte here. There are 2 megakaryocytes clustered together. There are a few megakaryocytes clustered together. And they're small, they are dwarf megakaryocytes, and the lobation is reduced. So normally we have multi-lobated megakaryocytes. Here it is 1 or 2 lobes. And in the background, you can see a lot of granulocytic cells and immature granulocytic cells. So you see neutrophils here, there are eosinophils, there are myelocytes, there are blasts. So all these cells are seen in the background. Chronic phase or CPC in majority of the cases, whereas some cases present with accelerated phase or some cases progress to accelerated phase and blast phase. So in these cases, the organomegaly is increased, the patients have worse symptoms. And if you see the white blood cell count, which is much higher, the platelet count is also much higher. You can go even up to 10 lakhs. Another important feature is blast count. So blast count can range from 10 to 19%, whereas in chronic phase it is less than 10%. It's usually in the range of 5 to 6%, something like that. The basophils are increased to more than 20% in peripheral blood, and there can be other genetic changes. So this is the WHO criteria. It highlights the points we just saw. So again, if you see there is increased cell proliferation, and also you can have increasing fibrosis in the peripheral in the bone marrow. The terminal phase or the most severe phase is the blast phase. It is almost like an acute leukemia. So here the blasts are more than 20%. The blast can proliferate outside the bone marrow. There are large clusters of or aggregates of blasts in the bone marrow. Again, the blast phase can be a myeloid blast phase or lymphoid blast phase, similar to acute myeloid leukemia or acute lymphoblastic leukemia. 70% of them are myeloid leukemias and 20 to 30% are lymphoid leukemias. So this is a picture where you can see a lot of blasts. So all the cells are blasts, large cells, high NC ratio, dark chromatin, etc. And if you see the bone marrow, there is only blasts present. There is no normal hematopoietic cells, and then normal hematopoietic cells are very less in number. You can have a megakaryocyte here. We have a few neutrophils here, but majority of the cells are blasts. So what are the tests we do? We do cytogenetics, FISH, and RT-PCR. So in karyotyping, we look at the chromosomes, we look at the chromosome number, and we look at the chromosome structure. Here the number is normal. We have 46 chromosomes, but you can see that the chromosome 22 or the Philadelphia chromosome is shorter compared to the normal chromosome 22. This is because there is translocation with chromosome 9. Apart from translocation 922, other chromosomal abnormalities can also occur, especially in blast crisis. Another test we do is a fluorescent in situ hybridization. Here we have fluorescent probes for these two genes, BCR and ABL1 gene. Normally what happens, this is the normal individual where the BCR and ABL, that is chromosome 9 and 22, are present in different, are present far apart. So the signals are seen far apart. So you have a red signal and a green signal which are far apart. Whereas in the CML or chronic myeloid leukemia, there is fusion. So because of that, the green and the red ones come together. So this results in a fusion signal or a yellow signal. So this indicates presence of BCR-ABL1 fusion. Other test we do is the RT-PCR test. This is to detect the fusion of BCR-ABL at a genetic level. So here we take the blood sample, extract the RNA, and then do a PCR reaction. So in this, we look at the detection of BCR and ABL1 fusion, which can be 210, 230, or 180 fusion products. So how do we treat this? So first, when we diagnose this, we do all the investigations. We do a risk assessment or a scoring of the disease. So there are different types of score, which tells us the risk group. These are so-called Euro, UTOS, different types of score, and the criteria like age, spleen, platelet count, and the blood counts are taken into account, and risk categorization is done. Based on low or intermediate or high risk, we decide what type of therapy the patient receives. The common type of therapy is used as imatinib. So it was described as a bullet against cancer in the 2000 issue of Time. So this is one of the first targeted therapy used in any cancers. So it targets the BCR-ABL1 protein directly, thereby stopping the proliferation of cells and giving relief from the symptoms associated with CML. Sometimes the disease becomes resistant to imatinib. In that case, we use different newer types of tyrosine kinase inhibitors. This includes dasatinib, nilotinib, etc. Once the treatment is given, we assess the response using hematological criteria, cytogenetic, and molecular criteria. So coming to the conclusion, it is a common malignancy. It is seen in hematology practice. It is important because it has specific cytogenetic and molecular genetic abnormality, which helps in diagnosing the disease and even following up the disease. Because we understand the molecular basis of the disease, it has led to targeted therapy, the example being imatinib, and advances in laboratory therapy help us in understanding the disease after treatment also to assess how well the treatments has worked. So now we move on to other Mpns. So The other Mpns are put together because they share some common molecular pathogenesis. These include polycythemia vera, essential thrombocythemia, and primary myelofibrosis. So they have a different type of mutation which causes this disease. So we saw that BCR-ABL1 is the cause of CML, whereas in all these other Mpns, the Philadelphia chromosome or PS chromosome is negative. So what other mutations are present here? JAK2 mutation. So mutation in the JAK2 gene. So that is the most common mutation seen in this group of disorders. In addition, we have mutation in MPL gene and CALR gene. So what does this mutation do? So the patient has a mutation in JAK2, so how does it affect? So normally this JAK2 affects downstream pathways which lead to proliferation of different types of cells. So pathways include RAS pathway, PA3K, AKT pathway. Normally there is a counter check to these pathways. In this myeloproliferative neoplasms, they have constitutive activation, meaning there is no feedback loop, resulting in continuous activation of these pathways, which leads to increased cell survival in this proliferation. Similar thing with MPL. So MPL is another gene which codes for the thrombopoietin receptor. So thrombopoietin, you have heard of the term erythropoietin. So thrombopoietin is a similar molecule which is essential for proliferation of megakaryocytes and other hematopoietic cells. So when there is an abnormal MPL gene, it produces an abnormal MPL protein. So this results in continuous activation of this protein even without the TPO being present, resulting in increased cellular proliferation. The same with another gene, calreticulin gene, which produces a calreticulin mutation. So how common are these mutations? The JAK2 is the most common mutation. So JAK2 stands for Janus tyrosine kinase, named after this Greek god. More than 95% of polycythemia vera patients have this JAK2 B617F mutation. So B617F indicates a point mutator. That is point mutation leading on to amino acid change at position 617. A small proportion have a JAK2 mutation but at a different exon. 50 to 60% of primary myelofibrosis and ET patients also have this mutation. So by and large, the most common mutation is a JAK2 mutation in this other Mpns. Other mutations seen are calreticulin mutation and MPL mutation. So these are lesser in percentage compared to JAK2. A few of these diseases have all these three negative. All these Mpns have a few things or clinical features which are common. This include thrombosis. So because of increased cellular proliferation, there is thrombosis. They can have a tendency to have a myelofibrosis. So what is myelofibrosis? There is increase in fibrosis or fibers, extramedullary fibrotic fibers in the bone marrow. Because of that, there is extramedullary proliferation. The body tries to compensate by increasing hematopoiesis in other tissues like spleen. So because of this, there is increase in splenomegaly. And all these myeloproliferative neoplasms, they have a propensity for transforming into acute leukemia. So when they are present just as MPNs, the survival is long. It can go up to 5 to 10 years or even more. But when they transform or progress to acute leukemia, the survival or the patient doesn't survive beyond a few weeks or months. Also, compared to the prognosis, essential thrombocythemia shown in red, the survival is more compared to polycythemia vera and primary myelofibrosis. You can see the PMF for primary myelofibrosis, the survival is less. That is just 6 years is the median survival. Whereas for essential thrombocythemia, the median survival can go up to 20 years or more. We'll see each of these diseases one by one. We'll just see the salient features. So we'll start with polycythemia vera. So in polycythemia, the word means it's an abnormally increased red cell mass. So it can occur when there is reduced plasma volume or increased red cell number. It can be primary or secondary. So secondary is something happening outside the bone marrow. Primary is something which is primarily due to affected bone marrow. So what are the causes of secondary polycythemia? It can be acquired causes because of various stimuli like smoking, obesity, sleep apnea, etc. Because of this, the body is trying to produce increased red blood cells as a response to the associated hypoxia. Some neoplasms secrete EPO, erythropoietin, which can stimulate the red blood cell production. Congenital causes, patients can have high affinity hemoglobin. So the hemoglobin is not, the oxygen is not separated from the hemoglobin. So because of that, body produces more red blood cells. There is problem or mutation in the oxygen sensing pathways. Whereas primary can be because of mutations in the EPOR gene or because of mutations affecting myeloproliferative neoplasms like polycythemia vera. Normally, the red blood cell production depends on the hormone erythropoietin. Erythropoietin is produced by the kidney, which is necessary for red blood cell production. In normal conditions, there is a feedback loop which inhibits EPO when there is adequate red blood cell produced or adequate hemoglobin. Whereas what happens, this feedback loop is inhibited or feedback loop is removed in polycythemia vera. So because of this, there is uncontrolled proliferation of red blood cells. Most of these patients have mutations in JAK2, which we have seen. And because of this, there's increased proliferation of all cell lineages, granulocytic cells, erythroid cells, megakaryocytic cells, etc. So coming to the diagnostic rate, how do we diagnose this? So the patient has a high hemoglobin, more than 16.5 in men, 16 in women. Bone marrow biopsy shows hypercellularity. There's a lot of blood cells within the bone marrow. Normally, we have a mixture of fat cells and bone marrow cells. Here, the fat cells are replaced by just bone marrow cells. JAK2 mutation is present in these patients. And because of this increased red blood cell proliferation, erythropoietin level is secondarily pushed down. There is a slight male predominance. The symptoms are mainly due to associated increased blood cells. So, because of this, there is hypertension and vascular abnormalities, which leads to headache, dizziness, pruritus, etc. There is a lot of cells in the peripheral blood, so they go and clog the blood vessels. So this results in thrombosis of mesenteric vein, thrombosis of portal vein, etc., etc. Physical findings: there is organomegaly, there is erythromelalgia and plethora. You can see the face with ruddy complexion. There is plethoric phases. There can be hemorrhages. This is the retinal hemorrhage, and you can see when the peripheral blood you have increased coloration. So there can be pruritus, erythromelalgia, and sphenomegaly, and gout presence because there is increased turnover. So in peripheral blood, there is increase in hemoglobin and increase in WBC count. What happens to the bone marrow? So the bone marrow with pad myeliosis. Pad myeliosis means increase in all blood cell lineage. There is increase in megakaryocytes, increase in red blood cell, precursors are erythroblast, increase in granulocytic cells, etc. The megakaryocytes are pleomorphic and they are loosely clustered. In spleen and liver, there is congestion of these blood cells, and this section to the spleen which shows megakaryocytes in the splenic architecture, which we normally don't see because of increased proliferation and stasis. They come and clog the blood vessels or the splenic tissues also. Normally, it's a polycythemic phase which progresses on to spent phase or a leukemic phase in case of polycythemia vera. The survival is usually long, even without treatment. It goes on for 10 to 15 years. And the final stages, it transforms into a fibrotic phase or a spent phase. Next, coming to essential thrombocytopenia, essential thrombocythemia or essential thrombocytosis. It is a clonal proliferation that involves mainly the megakaryocytic lineage. So, as the name implies, the thrombocythemia, the primary presentation is increase in the platelet count. So, the thrombocytosis more than 4.5 lakhs is the primary feature. As you know, the normal platelet count In an adult is 1.5 to 4 lakhs. Here, the platelet count is almost always more than 4.5 lakhs. Here, the bone marrow biopsy show normocellular bone marrow, but there is increased number of megakaryocytes. It is primarily a disease involving the megakaryocytic lineage. How do we diagnose this? The platelet count is high, it is more than 4.5 lakhs. Bone marrow biopsy shows proliferation of the megakaryocytic lineage. And we have one of these JAK2 KLR or MPN mutation. It is a disease of middle to old age, and it involves blood, bone marrow, and spleen. A large proportion of the patients can be asymptomatic. They are diagnosed after routine examination. Thrombosis can occur because of increase in platelets. So this is the peripheral blood in the patient with ET, interstitial thrombocytopenia. Here we can see the platelets are increased and they occur in clumps. Bone marrow shows increased megakaryocytes. So you can see here 4 megakaryocytes stuck to each other. And even if you see the lobation here, it is much more folded up on compared to a normal megakaryocyte. Normal megakaryocyte, it is multi-lobe. Here it is multi-lobed as well as multi-segmented. You can see bone marrow biopsy here. You can see the nuclei folded upon each other, and normally you have 4 to 8 lobes here. The lobes can go even up to 50 to 100 times compared to a normal megakaryocyte. So this increased lobation in the megakaryocyte is a characteristic feature seen in E. Increase in platelet count can also occur in other conditions, benign conditions. This needs to be separated from essential thrombocytopenia, which is basically a neoplasm or a cancer. How do you? So, what are the causes of this reactive thrombocytosis, iron deficiency, infections, and surgeries? In reactive thrombocytosis, the increase in platelet count is transient, meaning it stays on for some time till the stimulus is there. After that, it goes back to normal levels. The third myeloproliferative neoplasm in this category is primary myelofibrosis. The pre-fibrotic one constitutes 50% of the cases. The fibrotic one constitutes the other 50% of the cases. It is also a disease of advancing age. So we need to remember that all these myeloproliferative neoplasms occur in older age or middle age. They are very uncommon in children. And all this involve blood, bone marrow, liver, and spleen. And many of them can occur asymptomatic, like 30% is asymptomatic and diagnosed on routine examination. And only about 50% of the patients have constitutional symptoms. Sphenometry is a characteristic feature seen in primary myelofibrosis because the bone marrow is fibrotic. The spleen enlarges and tries to compensate by producing extramedullary hematopoiesis. Again, the progression of primary myelofibrosis occurs in different stages. Like we have chronic phase, accelerated phase, blast phase, CML, polycythemia vera, pre-phase, spent phase, and fibrotic phase. So here also we have pre-fibrotic phase, fibrotic phase, and primary myelofibrosis. Pre-fibrotic or early PMF, the survival is better. The patient, about 70 to 80% of the patients can survive for 5 to 10 years. Whereas in advanced PMF, the survival rate is not very high. In all these Mpns, especially in PMF, the fibrosis is caused because of certain factors or cytokines produced by megakaryocytes. This is EGF, PDGF, etc., which stimulate the stromal cells to produce fibrosis. How do we diagnose this pre-fibrotic PMF? In the bone marrow, there is megakaryocytic proliferation and atypia, and reticular fibrosis not prominent in the early stages. We should have mutation in JAK2, KLR, or NPN, or other clonal marker, and presence of minor criteria, including anemia, leukocytosis, or splenomegaly. The overt or fibrotic PMF has a slightly different criteria. Again, we have megakaryocytic proliferation, BCR-ABL1 is negative, JAK2 CALR-MBL is positive. Here we have increased LDH and leukoerythroblastosis. So what is leukoerythroblastosis? Here, leukoerythroblastosis meaning there is left shift in the erythroid as well as the myeloid lineage. So in addition to neutrophils, we have myelocytes and metamyelocytes in the peripheral blood, and we have nucleated RBCs in the peripheral blood. So the combination of these two is called leukoerythroblastosis. This can occur in a variety of conditions, but it is fairly common in primary myelofibrosis. And because of fibrosis, we have an abnormal shaped red cells. So what we call teardropping of red cells. So this is a characteristic feature seen in fibrotic bone marrow. Because the bone marrow is fibrosis, to navigate the bone marrow to come out, the cells undergo some deformation. The bone marrow aspirate when performed on a patient with fibrosis. Because there is fibrosis, it's difficult to aspirate the bone marrow. So many times we don't get any aspirate material. So what is this? This is called a dry tap. In this case, the biopsy helps because biopsy uses a larger needle and takes out a small piece of bone. So when we do a biopsy, we can see a hypercellular bone marrow. You can see here there's less number of fat. The cellularity is increased, and we have this megakaryocytes which are very abnormal. So they are atypical. There are large megakaryocytes, there are small megakaryocytes, and they have this very dark, multilobated nuclei. So all these features suggest that it is a primary myelofibrosis. So we have this dense, large clusters. They are very hyper chromatic. So we use the term bulbous, as you can see, some bulb shape, or it can be cloud shape. It's folded upon each other with the light and dark areas interspersed between them. So all these are features of myeloproliferative neoplasm, especially primary myelofibrosis. And again, we see a lot of this megakaryocytes here. So normally megakaryocytes are scattered. Here we have this megakaryocytes stuck to each other and with multi-lobulated megakaryocytes with cloud or bulbous forms. And again, you can see the sinusoids are dilated. So you can see this white spaces. The sinusoids are dilated because of this fibrosis. And you can see hematopoiesis happening within the sinusoids. And this is a reticulin stain. This stain we do to understand fibrosis. So we can see this fibrotic brown fibers. Normally they are very less in number or near absent. Here you can see they are present throughout the bone marrow. This is a reticulin stain to show the fibrosis. These are this black-brown structures, black-brown fibers. Normally, these are absent or very less. Here you can see the increased multifold. You can see this collagen fibrosis here, blue strands, and also this H&E stain to show the background fibrosis and this increase in thickness of the bones. Osteosclerosis and fibrosis are features of myelofibrosis. When in the last stages or overt fibrotic phase, there is just bone everywhere. Bone and small, very small little bone marrow space, which is also fibrotic. So when there is just bone and no bone marrow, it leads to the final stage of primary myelofibrosis, where there is no red blood cell production. The patient depends on transfusions for anemia, and even the other blood cell counts go low. Early primary myelofibrosis and essential thrombocythemia have some similar features. They need to be differentiated. One feature is the presence of cellularity. So cellularity is normal in essential thrombocytopenia. So how do we assess the cause of, assess the MPN burden affecting the patient? So apart from the baseline health, the patients can have vascular events. They can have thrombosis affecting the different vessels. The disease progresses to a spent phase or acute leukemia. Sphenometry can be massive. Cytopenias can occur. And other symptoms also affect the treatment choice. Treatment can be given to reduce the blood counts to cause cytopenia so that other risks like thrombosis are reduced. Vascular complications can occur. So because of this, we give anti-thrombotic drugs. Splenomegaly is there, so it leads to symptoms of splenomegaly. To relieve that, treatment can be given. We use a combination of anti-thrombotic drugs and cytoreductive drugs. In low-risk patients, aspirin is given to prevent blood clots in high-risk patients. In addition to aspirin, we give hydroxyurea to reduce the blood cell count numbers. In polycythemia vera, because the primary problem is increase in red blood cells, we can do phlebotomy, that is taking out blood, bleeding out the blood in a controlled manner to keep the hematocrit less than 45% to reduce the effects of the increased hemoglobin levels. In essential thrombocythemia, whether it is low or high risk, in low risk we just give aspirin, whereas in high risk we give hydroxyurea in addition to aspirin. Similar in primary myelofibrosis, in low or intermediate risk, the treatment is hydria to reduce the spleen size and symptomatic treatment for anemia, whereas in high risk, a bone marrow transplant needs to be done. So in summary, all this myeloproliferative neoplasms results in excess production of normal mature blood cells. Bone marrow helps in the diagnosis of all these conditions. They have characteristic bone marrow morphological pictures, especially the megakaryocyte morphology. Fibrosis can occur in all these cases, especially in primary myelofibrosis. Sphenometry is a consistent feature which needs to be examined in all suspected cases. And all this have complications ranging from thrombosis, bleeding, and progression to acute leukemia. So we'll stop here. If you have any questions or any clarifications, you can either ask in the chat box or unmute yourself and ask your question. So if there's no questions, we will end the session. And I think Rahul is there. We'll close the session, Rahul. Thank you.